back, I will pick on, just so you know. Okay.
I'll raise my hand.
As Denise said, my name is Connie Malmborg. I have been a nurse at Northern Maine Medical Center for 35 years. I presently work as a nurse and supervisor, and when I came to school here, I did a double major in nursing and psychiatry. What I have been asked to present today is psych emergencies. As a supervisor, a good part of our time is spent in emergency rooms, so we have lots of experiences to share today. What I'd like to cover is some of the reasons why we consider them psych emergencies when they do come into the emergency room. Our number one thing, I have to say, would probably be our drug seekers. These are the people that come in with the most common complaints. I have a toothache, and nothing seems to be taking care of it. And ibuprofen's not covering it, Advil's not covering it. We need some narcotics. Kind of hard to disprove because many of these have been meth users in the past, so their teeth already are a mess. So you can't say they're not having a toothache because chances are they probably are. And they have used this excuse many times in the past. And in the past, it has been easier for these people to get narcotics in the emergency room. Things have become a lot stricter as far as physicians being able to order narcotics freely. And we now have something where the physicians can actually sign into a computer, and it connects them to the drugstores in Aroostook County. And you can type in a patient's name, and it will tell you if the patient has been prescribed any benzos or narcotics in the past, when and how many. So needless to say, a lot of these patients' names come up frequently. So the physician will probably give them 1 or 2 cassettes to go, and then they're free to put them on their way. Another thing that happens is hospitals from Fulton, Tammy, Carey will frequently call and say, Joe Blow has been here and at Carey complaining of backache or toothache and is looking for drugs. So it kind of gives us a heads up so that we don't feed into their substance abuse problems. Back pain is the other problem, the other complaint that these drug seekers frequently use because, again, very hard to disprove that someone is having back pain. So that's probably our number one big complaint from our drug seekers. The second thing that we get frequently that we take a lot more serious is suicidal ideations. If they come in with complaining of suicidal ideations with a plan, needless to say, we take this very seriously because chances are when you have a plan, you're more likely to follow up. Most of them have been brought in by family, loved ones. Not too many of them just walk in freely off the street. And that's the sad part, but fortunately, when families are close enough to detect differences and depression, increasing depression with their loved ones, particularly children, unbelievably, the past few years, it has blown my mind how many school-age children are suicidal or homicidal. During school, a lot of it has to do with bullying. I don't know how come bullying has become such a big issue the last 5 to 10 years, but kids are just blown away by the bullying and they can't deal with it and literally have plans on how they're going to take their own life. And I'm talking as young as 6 years old. Homicidal, something I had never heard of in my life for a child in the past. We see these kids, 6, 7, 8, 9 years old, with plans on how they are going to kill their parents. We had a 4-year-old who had looked on the internet different methods that he could use to kill his parents while they were asleep. We do have here at Northern Maine Medical Center a child adolescent psych unit and an adult psych unit. Both of them are voluntary. During the school year, our child unit is quite full. And we are the only ones north of Bangor, actually, that has this unit. And thank goodness we do have it. And I think we've saved a lot of children from hurting themselves and hurting others. These children come from torn homes, broken up homes, parents are divorced, parents are substance abuse users, alcoholics, and they just don't know how to deal with it. So a lot of it is picked up in schools by the guidance counselors and the teachers who are much more aware of how to help these children. And adolescence, common theme is breakups with boyfriends, schoolwork being too intense, and college kids, during finals, we get our share of college students around finals time. They just can't deal with the pressure, it becomes overwhelming, and they just feel at that point that their life is just so overwhelming that the only solution is suicide. It's sad, but there is help for them, and there's a lot of helplines out there that a lot of students are not aware of, and we do provide all this information for them. When someone does come in with suicidal ideations or homicidal ideations, after doing a medical clearance, we of course call in AMHC, and they do a full, thorough workup, and then decide if that person is actually safe to go home, because a person may contract for safety. Yeah, I'll be okay. I'm not going to do anything. I'm going to go home, and I'm not going to do anything. You have to read a lot between the lines with psych patients. Most of it is nonverbals, and I'm sure you've covered verbal communication versus nonverbals. Nonverbal is the number one thing when you're dealing with any psych patient, because what they don't tell you is the thing that's probably the most important of all. Their eye contact, their speech, their tone of voice, how they avoid, how they're looking around. That's the things that you need to pick up, not so much the words that they're telling you. And most people will minimize their symptoms. If you have someone come in for detox, for example, which is another big problem around here, and I speak for around here because I've worked here all my life. If they tell you they have been drinking every day a 12-pack, you pretty much know you can double that. If you ask them, are you using any street drugs? Well, I smoke an occasional joint. Well, you know, they're probably talking about a baggie a day. They don't often tell you about the pain pills, narcotics, the benzos. That seems to be the most popular drugs right now. 20, 30 years ago, marijuana was the drug of choice. Now we rarely even hear about that. The narcotics, however, is huge, mostly because it's very easily accessible. They go into their parents' closets. It's easy enough to get a prescription from a physician, and you can buy it quite readily off the street. And technically, it's legal, as opposed to cocaine, LSD, or any of the other drugs. So it is a big issue, and it's something to be taken very seriously. Psychosis is also another disorder that we see frequently. And you can become psychotic from drug use, smoking a bad joint that was laced with LSD. We see it all the time. Why? I don't know. It's, I scared myself there. When a patient comes in and they're psychotic, they're not thinking clearly, they're not conversing clearly, and oftentimes it's very difficult to get any type of a history from them. They can be psychotic if they have a diagnosis of schizophrenia. And schizophrenia is a disease that very commonly occurs in males, and it peaks between the age of 17 to 20 years old. they can have a normal childhood and something happens to their brain between the age of 17 and 19 that their parents will often bring them in and say, he's just not acting normal. You know, he's talking to himself more, and when you talk to him, there's this blank stare, like he doesn't hear you, yet he'll be in his room by himself for hours talking to somebody that's not there. So a schizophrenic will often present with hallucinations, and this can be visual hallucinations. They see something that other people don't see. Auditory hallucinations, very, very common. They will hear voices, and these voices frequently will tell them things to do. It can be to cut themselves, it can be to kill themselves, or hurt somebody else, or run in the traffic naked, or it could be anything. Tactile hallucinations, where they feel like someone is touching them all the time. And this I find if a child has been abused or molested as a younger child, this seems to be the number one presentation. It's like a PTSD thing that kind of forms in the tactile hallucination. It's very scary. It's a lot more difficult to treat because by the time they come to us, and there's that psychotic, we frequently need police assistance because they tend to become quite violent if you are trying to help them. For example, we had this case on Saturday, a young boy, 18 years old, diagnosed with schizophrenia last year, and he came in with the police. He was so aggressive and so violent, he would literally pick up a stretcher and throw it across the room. They have this unbelievable strength that it's crazy. Of course, you try not to use restraints unless you absolutely have to. That's the last ditch thing. And if a person has been abused in the past, you can just imagine that being tied down on a stretcher is not going to help their PTSD any. This boy, we gave enough medication that would have killed a horse, and it didn't touch him for hours. So it becomes quite frightening to deal with them. The number one thing I can recommend to all of you, if you do have to work in emergency situations and you're dealing with violent, aggressive type psychotic patients like this, try as hard as you can not to show your fear and to really listen to them, because their biggest fear is that nobody understands them, and truly it is very difficult to understand what they're going through if you've never been through it. But hear what they're saying and show them that you do accept them for what they're going through, who they are. You're not there to pass judgment. And if you can develop that trust relationship within the first 5-10 minutes, you're on Golden Street. If they lose trust in you that first few minutes, whether you're in there and it can be as minimal as rolling your eyes, they will pick up on that and you have lost them. You will not reach that patient. So you may not be the right patient, the person for this to treat this patient. Colors can be something that can trigger a psychotic patient. I once showed up to ER because they were having an aggressive patient, and usually I can de-escalate a patient regardless of what the problem is. I was wearing a green scrub, and the second this guy saw me with the green scrub, he totally wigged out. He stormed out of that ER, he broke a door, he broke everything on his way out the door and ran into the street, almost got bumped. I couldn't understand what in the world had happened. All I had said was my name and how can I help you? Well, come to find out, his mom was there and she said, oh my God, is there any way you can go change your scrub? I thought, okay. She goes, the color green throws him right over the edge. No rhyme or reason to it, it just did. I changed into another colored scrub and it was fine. By the time he came back in, we sat down, he was able to talk, but different odd things that you would never think about can throw a person right over the edge. A psychotic person often is has a lot of religious preoccupations. They either think they are God, or God is talking directly to them, or worst case scenario is the opposite. They think they're the devil, or the devil is telling them how they need to lead their life and what they should do and how to attack other patients or other people. It can be a little frightening. We do have some great drugs out there that helps. I'm sure you've all heard of vitamin A, which is our famous Ativan. We love our Ativan. The other newer drugs that are used now to treat psychosis that works very well is Geodone. And you may see this on your state boards because they do have a lot of psych questions, and they tend to go with the, what newer drugs are they using to treat these types of disorders. So Ativan, Geodone, and Zyprexa. Risperidol for schizophrenics is probably the #1 drug. They do work well. They can take quite a while, as in the case of this young fella. I can't even tell you how much medications we had to give him before he even remotely calmed down whatsoever. Now, whether or not AMHC comes in for a patient like this, if a patient is psychotic, obviously they're not going to be a voluntary patient because they have no clue who they are, what they're doing, or where they're going. That leads us to look elsewhere for an involuntary admission, because they are not safe at this point to go home. Even though they tell you they're safe, you know they are not safe. They will hurt themselves or they will hurt somebody else. The closest involuntary bed in Maine is Acadia. And we have to go through Acadia first to see if they have beds, and then move on to Dorothea Dix and Spring Harbor, so on and so forth. Finding a bed on a weekend is like finding a dentist on a weekend. When you do blue papers, it's something. It's very serious. First of all, needless to say, it stays on the record forever. And a judge, after you fill out the paperwork, if you get an accepting bed, the physician has to fill out half of the paperwork, and then you have to find a judge to sign these papers. Well, on this weekend, we actually found a bed. Couldn't believe it. The closest judge we could find was in Presque Isle. So we had to send the sheriff all the way to Presque Isle and back before we could even think of putting the patient on the road. And then Acadia we have to fax our papers to Acadia. They have to approve that everything is copacetic before they can tell us to put the patient on the road. So it's kind of a lengthy procedure, but it is what it is. When a patient is involuntary, they can keep them up to 72 hours only. If they feel a patient needs to stay longer than 72 hours, then it becomes a court thing, and they have to report, and the court has to approve that, yes, indeed, the patient needs to stay longer. There's not a lot of beds, and we used to be able to keep patients involuntary at the NHI a long time ago, probably before all of you were born, for months and sometimes years at a time. It's no longer like that. So there are a lot of patients out there that could definitely use inpatient psychiatric help long term. It's not as easy as it used to be. So we get a lot of repeats, and they keep coming back, and they come back. So if every single time that a patient comes back, whether it's once a week for the same thing, you have to treat each incident as though it's the first time you're seeing this patient, and always treat them with respect and dignity, and never look at your coworker and say, oh my God, here we go again. I can't believe it. Why isn't this guy just staying on his meds? Because the main reason that they keep going backwards is once they start feeling better, they think, okay, great, I'm fine. I'm going to get off my psych meds, because they know that drinking alcohol and doing other drugs with their psych meds often does not agree with them at all, and they become worse again. So rather than giving up the street drugs, they will give up their psych meds, and then we're back on the same roller coaster, and it just becomes one vicious cycle. So we do have a lot of repeat clients for the same thing. Same thing with the alcoholics. Our Friday nights, particularly, we'll get our influx of patients that come in very agitated, very drunk, wanting detox. What does a patient do when they're drunk? They think their world is the worst of anyone they've ever met. I can't live like this. I just want to kill myself. I can't go on like this. Well, the minute they say, I want to kill myself, automatically they have to be taken seriously as though it's a serious suicide plan. So we do have to admit these patients also. These can go to a medical floor for detox for the first 24 hours. Generally, by the time they sober up the next morning, they realize they were really stupid and they said some really dumb things and they just want out of there. Sometimes they come in once a week, it's the same thing, but we have to treat them as every single time, take it seriously, because who's more impulsive than a drunk person? They say they're drunk and you think, oh yeah, right, they're never going to do anything. When a person's intoxicated, they certainly can follow through with an impulse, not really meaning to, but it can happen. Manic depression is another diagnosis that we see often. Patients with manic depression or bipolar, which is the same thing, love their manic phase. They're very productive, they're very energetic. They can get more work done in an hour than a regular person can get in 2 weeks. They love that. What happens though is it's like a battery. You run out of gas after a while. So then they start to cycle down, and that's when they go through their depressive stage. And then they can't stand it because they're used to their high energy level. They're used to being the life of the party. They love having fun. They love people. They love everything about life. And then when they get down, they can't even get out of bed. They don't want to eat, or all they want to do is eat, and they become extremely depressed and often suicidal at that point. Why do bipolars get off their meds? They love their manic phase, and what the bipolar meds do is brings them down to an even keel, but they don't have that high anymore. So oftentimes they'll weigh their pros and cons, and they feel that, you know, I'd rather take the chance of not going through a depression than be on these meds, which keeps me just so blah. They see it as just bland. We put them back on their meds, they feel great for a while, but then they start missing their manic phases, and frequently it's the same scenario. They'll get off their meds, and then they start the cycle again. If only we could just shake them and say, if you'd stay on your meds, you wouldn't have these cyclic ups and downs, but we can't, unfortunately. Psych is, it's definitely interesting. It's never boring, and it's never the same. And it is very sad. Most people don't understand, particularly families. The patients often feel misunderstood, and they are. They literally are, because how do you make sense of your loved one who suffers from a major depressive disorder, and they're always down? It's very difficult. It's not just a disease that affects the person. It affects the whole family. You can't have your spouse or your child or your sibling going through all this and expect that it's not going to affect you one way or another. So families tend to either minimize it, don't talk about it, or just ignore the whole thing. And then they feel they're alone, and technically they are alone. We can't fix the whole family. We have tried very hard to do more education in the community and with families. When we do get a patient, I'll speak for myself, I usually try to involve the whole entire family with the disease process. And what medications we're giving and why, and the importance of them staying on their medications. Part of the problem is they go home with these medications. Say they suffer severe anxiety, is another one. You put them on benzos. Benzos are addicting. They love the feeling when they are on their medications, and then what a little bit was taking care of the problem, suddenly, well, I'll try. One Ativan worked really good. I bet you two will be even better. And next thing you know, they are addicted to their Ativan. And so families start hiding medications from patients. As strange as that may sound, it's the reality of it because they're afraid of overdosing. And there's no quick fix for any of it. We get a lot of elderly patients that the family will bring them in and say, they were fine until last week, and suddenly they're acting so weird. They're confused and they're agitated, and mom even started swinging at me, and she was the most simple, sweet person I've ever met in my life. I don't understand what's going on. And I think she has dementia. That's always the first thing that a person will think of when you think of a geriatric patient. The reason we do medical clearance on all psych patients, of whatever diagnosis they're coming in with, is because it may very well be as simple as a medical problem. And with geriatrics, I found that very frequently you run a urinalysis and a urine tox screen, you're not going to find drugs in their urine most of the time. But frequently you do find that they have a urinary tract infection. And when you're young, you don't think of a urinary tract infection as being this detrimental, but for an elderly person, it's amazing. It literally can make them psychotic. Treat them with antibiotics and they're fine, never to be seen again. Pneumonia is another infection that can cause psychosis in geriatric populations. Actually, any infectious process, so when you do a white count and you see their white count is elevated, if their urine is clean, they have an infectious process going on, so they'll often just get automatically treated with antibiotics and their psychosis will clear up as easy as that. So if you ever work with geriatrics and you notice sudden onset of strange behavior, don't automatically assume that it's Alzheimer's or dementia. Think first medical, because it's actually the easiest to clear up and it's the easiest to diagnose. It's very difficult to diagnose dementia. CAT scans, MRIs will show some deterioration, but it's not going to be the first line of diagnosis that you're going to do. So let's do a urinalysis and see if there's anything going on there. Even if you ask them, are you having trouble with urination and pain, burning, discomfort? At that point, they're psychotic. They don't even know what you're talking about. So if you can often get the problem treated right out of the gate if you think medical before you think psych. Particularly in the elderly, it happens all the time. Bath salts, new drug of the century. Fortunately for us, we've only had 3 instances here at Northern Maine Medical Center. Very scary. Downstate, it's much more rampant and very difficult to treat and very difficult to diagnose because there is no drug test. There's no drug test that you can do that'll tell you that it's bath salts for sure. But they present in the worst psychotic behavior you'll ever see, and it's really, really scary. Again, they're so strong. We had the first one that I saw, he came in covered in cigarette burns all over his body, literally all over his body, and his child also, because he was seeing the bugs on his body and trying to put out the bugs with his cigarette. And a 2-year-old, it's one thing to do it to yourself, but when you start putting cigarette burns on your 2-year-old because you're afraid that they're being overtaken by bugs, it's really sad and it's really, really scary. The police are coming up with some new drug screening type things that they feel that they can help to diagnose bath salts quicker. We'll see. I hope that one day that we do have one test that we can do and this is it. Unfortunately, there's not even a medication out there. Heavy doses of Ativan, risperidol, things that you would normally do for psychosis, but in much larger doses is how we're treating bath salt victims right now, if they don't come in already dead. It's too bad that this is where our life is going. You know, people are trying to find bigger, better drugs, and what can you do about it? You know, it's a scary place to bring up children, and they want to fit in. Major depression is another one that can be very difficult to diagnose. They will often come into the ER complaining of something vague. I'm kind of having chest pains, like the last couple of weeks, or really, tell me about it. And then they'll talk about their chest pain, but you can tell when a person comes in with chest pain, you know if it's chest pain. They're grabbing their chest, or they can describe it to a T. When someone comes in and it's vague, I'm kind of, well, yeah. Again, look at their nonverbals. What are their eyes telling you? Do they have sad eyes? Are they looking down? Do they look like they're on the verge of tears? The last one that I had that came in complaining of chest pain, did an EKG, did random cardiac tests, everything was ruling out, but she kept insisting, no, I'm having chest pain. So the doctor said, well, we really can't find anything, so we're going to let you go. So after the doctor left, I just sat down by her bed and I said, you look sad to me. Really? I said, you look more than sad. You look like you're depressed. And she just burst out crying. She says, half an hour ago, I just drove on the Trans-Canada and I wanted to drive my car into an 18-wheeler. And something stopped me at the last minute, and here I am. I didn't say, well, why didn't you come in here and tell me you're depressed, because that's like accusing them of something. You don't want to go down that alley. So I said, well, let's talk about, what's been causing the depression, and how long has this been going on, and what types of things are happening in your life, and how can we help you? And she had been suffering from depression for months, and on the outside, appearing to the rest of the world that everything was fine, able to go about her job, her family couldn't tell anything was wrong. She'd still have the meals put on the table, but inside she felt like she was dying a little bit every day, until one day she just couldn't take it anymore. Fortunately, she turned the car around and seeked help. So she's on the right track now, and I'm glad, I'm very glad for her. I'm glad she did follow through. But again, when they come into ER, just because they're saying one thing doesn't necessarily mean that you shouldn't dig a little bit deeper to find out if there's more going on, particularly if all tests come back negative. But they're still insisting that they have this issue. Of course, we do have the Munchausen syndrome people who, how many of you are familiar with Munchausen syndrome? They will either create illnesses and truly believe so much in their head that they have this, that they really have it. They really, really think that they have this. Or they'll create an illness for their children, which is even more common, or make their child sick so that they can bring them to ER, so that we can say, oh my God, what a good mommy you are. so sick. While in the background, you didn't realize that they're the ones that actually gave the Drano to the kid, so that they'd have a reason to bring them in to be treated. But Munchausen syndrome is, it's difficult to diagnose, and a person doesn't want to hear it. When you do figure out what's going on and you call them on it, hey, who would have given this Drano to this kid if it wasn't you? It's like, oh, they must have taken it on their own. It's their problem. It's not the child's. So it can be it's an interesting challenge, and it can happen with older people. Well, they'll create an illness where they truly believe they have an infection, or they truly believe they have pneumonia constantly, or whatever, and nobody believes them. Nobody wants to believe them, and test after test will prove negative. But in their head, they've so much talked themselves into thinking that they have it, that they have it. So that's another illness that's it's difficult to prove and it's difficult to treat. With something like Munchausen, there's no drugs that's going to take care of an issue like that. But long-term psychotherapy will definitely help. DBT, diabolical therapy, to kind of retrain their brain so that they're back on the train's back on the right track. We do have AMHC does a fabulous job. Fabulous. Unfortunately, they are so busy. It's not always easy to get in. We're fortunate enough in this area to have several psychiatrists and psychotherapists. So if you do know of someone or you yourself suffer from any of these illnesses, anxiety, depression, whatever, suicidal ideation, take it serious. See someone, suggest that they see someone and get treated. Doesn't mean that it has to be forever. Circumstantial depression happens very frequently. You have a major crisis in your life, parents dying, or house burning down, or it can be anything that a person is going through, or multiple things happening in a person's life that can make a person feel so depressed that they just can't snap out of it on their own. But yet they keep thinking, well, maybe tomorrow I'm going to feel better. Maybe tomorrow I'll feel better. But it gets worse. These types of people can be treated actually very easily. Antidepressants, we have meds that are so much better than they used to be in the past with fewer side effects. And they can be on it short term, and then they feel better, and time has passed so that all these crises, don't seem quite so severe anymore. So I'm definitely not going to push people toward medications, but in some cases it is the answer, particularly short term. One of the psychiatrists wanted me to make sure that I mention something called Beer's List. Has anybody here ever heard of Beer's List? What do you know about Beer's List? Guy in the yellow.
List of meds for geriatrics and mental problems.
Perfect. It's a list of medications, as he said, that you should actually try to avoid in geriatric population, because they tend to interact quite readily in a not positive way with other drugs. So when you have a geriatric who has multiple physical problems, they can have 10 different diagnoses. And some of these patients, unbelievable, they can be on 10, 20 meds in a day. And if any of you work with geriatrics at all and dealt with medications, it blows my mind every single time. I say take them off all their meds and start one at a time with what they absolutely need, but that's just me. So this Beer's List, which you'll probably see on your state boards, hint, hint, is it can be anything from benzos to beta blockers, people with asthma that are on beta blockers find that their COPD doesn't get any better. Why doesn't my COPD get any better? And yet you look at their meds and say, well, why are you on a beta blocker? Well, I don't know. Well, how long have you been on this med? Oh, I don't know, 10, 20, 30 years. Hello? The beta blocker is going to exacerbate their asthma and their COPD. Unfortunately, physicians are so busy that I find that they don't spend enough time when the patient goes to see them to literally review every single one of these medications. And some of them literally have been on all these meds for 10, 20 years. Could they be taken off some? Yeah, absolutely. We've done drug holidays on numerous patients, and they actually feel a million times better once they're off all these meds. The side effects of meds, if you take only one, probably you're going to do great. But what this Beers list does is it alerts you to what different meds can interact with each other and cause side effects that are going to create another problem, so that you'll actually need to get put on another medication to take care of that side effect. And now, well, now you have nausea constantly, so you need to get put on another medication to control your nausea. Oh, well, that's causing constipation. Well, now you get put on a medication to help with the constipation. So, again, you're on multiple meds for side effects more than the illness itself. I think physicians are getting a lot smarter with reviewing the Beers list with patients and educating patients on how different meds can have interact with each other. And I think that's so great. And one of the big things in the hospital, if you're an inpatient now, it's standard procedure for us to do medication teaching on all patients and their families. So if you come in, whether it's for tonsillectomy, whatever, pneumonia, they will be reviewing all of your medications and asking patients, why are you on this? And unbelievably, over half of the patients will say, I don't know. Should you not know what medications you're taking and why? I think so. And if we start soon enough, when patients are younger, then it becomes more routine, and when they become older, they don't automatically, get their cup of medications at the nursing home and, there we go, there's my meds. They'll actually be able to look at it and say, hey, I'm not familiar with this. What is this med? So education is a great thing. You can never teach your patients too much. And if you think you're harping on something that somebody else has already taught them, do it. Do it anyway. They'll thank you in the end, and you'll go home at the end of the day knowing you've done a great job. Because if you can help one patient figure out a medication that they were on that they shouldn't have been on, or maybe this is what's causing this side effect, which makes you take this med, which makes you take this med, it helps them to ask their physicians more appropriate questions. So I think we've come a long way, and with, nursing students are great at this. I love nursing students because one of the things that we expect from them is use those critical thinking skills. Don't assume that your patients are going to know everything, because most of the time they've been having the same treatments and the same meds for so long, they don't even know what to ask. They just think, well, the doctor said. The doctor feels I need to be on it. Maybe. But if that patient gets trained on what kind of questions to ask the physician, you will notice that your patients will be on fewer meds, and they're actually going to live longer and feel better. So that being said, that's my feel on how I feel about geriatrics being on 75 different pills at one time. Any questions so far? Am I good for time here? personalities. Definitely interesting, to say the least. The first one I ever had, I thought I was losing my mind, because my first assessment, when I did my full assessment on her, she was just the sweetest thing and answered all my questions appropriately, and life was beautiful. I came back in 10 minutes later, and it was a man. It was a man answering my questions. Literally a different voice. Her facial expressions had changed. Her body had changed. And this one was mean. And I thought, what is going on? Definitely time for me to have less coffee or a little break. So the doctor went in, and he met another person in that person. She had never been diagnosed with multiple personalities before. But when speaking with her family, the mom was like, yeah, she's different than other kids. She has her mood swings, and she's always been like that. She's, up and down, she's all over the place. Can't really concentrate in school. She's not a good student. Everything was kind of like negative, but the mother had kind of accepted that that's just her. We did admit her to psych, and digging deeper, she had been through a lot of abuse as a child, multiple times throughout probably the first 8 or 9 years of her life. And if you've ever seen the movie Sybil and thought that that was a joke and that it can't possibly happen, it can, and it is weird. It is weird because you can't treat the guy inside of her the same as the little girl. So it's quite extensive, very, very interesting. I thought so anyway. And we did with years and years of psychotherapy, and she ended up getting some ECT, actually, if I recall correctly, a series of ECT, which they do at Acadia. Now functions as one person and does very, very well. The second one that I had, and you never know, are they putting this on? Is this like a show? Because it's so comical, actually, when you first meet someone with multiple personalities that you think it can't possibly be real. They have to be making this up. The second one was a child, 10-year-old child, and it was 2 little girls inside, and they were like night and day. And this time it's like, I got this one. And sure enough, similar situation. She had been severely abused and molested as when she was younger, actually up until that time, by mom's multiple boyfriends and fathers. So it was a matter of helping her to deal with the PTSD so that she could let go of these other children running around inside of her head. So if you do see someone and you think that it's a joke and that they're putting it on, it's possible, but there's also that chance that it may very well be something so painful inside of them that this is their coping mechanism. And you can't really take it away from them. Coping mechanisms, regardless of how negative it may seem to you, is their only way of survival. Like a schizophrenic, you never want to give them enough medication, especially if they've had schizophrenia all their life and been on medications. They will have peaks and downs with their meds. And oftentimes their meds need to be readjusted because they get used to a certain level and then it'll have to be increased or changed completely. When we had this one girl, and we had a new psychiatrist, and she had decided we are going to medicate her. We're going to get rid of these voices once and for all. Well, she's had these voices all of her life, and for her, these voices were a fringe. They were literally, that was her coping skill, and this is the only way she could deal with life. So it It was not necessarily a negative thing in her life. At this point, she was having a crisis, and the voices had gotten to the point where they were telling her to do bad things. So she knew, this is not good. My voices don't normally tell me to do bad things. They tell me how to act around people, because generally schizophrenics don't do well in crowds or social settings. So the doctor decided we're going to get rid of all these voices. Medicated her, and she did. She got rid of all the voices. That girl panicked and tried to kill herself because she no longer had those voices, which she called her friends. They were soothing for her to tell her that everything was okay and we're going to go through this. So, rule number one: you don't necessarily need to have a goal of getting rid of all of the schizophrenics' voices. Because remember, they have lived with this all of their life. Just because it's making you uncomfortable doesn't necessarily mean that it's uncomfortable for them. Coping skill is a coping skill. And you will hear those terms, coping skills, probably for the rest of your career, because a coping skill can be anything from learning how to talk with others to coloring. Some people, when they are in a traumatic state or their mind is just so fast, the racing thoughts are so fast that they can't control it, will find that coloring a page is soothing to them. Another person will look at that and say, my God, they're adults. Why would we want to make an adult want to color? That's so childish. We're playing them beneath the level of what they can do. Maybe that's all they can do at that time. So listen to what they're saying. If they're telling you that coloring is a good coping skill for them, it's okay. It's okay. It's not about you. It's always about the patient. So listen to them and try very hard to empathize, which it's not always easy to empathize with a psychotic patient or any psych patient for that matter. But if you don't, you're going to find yourself putting judgment on these people. And they're never going to get clear treatment if you start doing that. So put your judgment aside. My trigger, I'll be honest, I have a hard time with perpetrators, child molesters. So when we have children in the psych unit that have been molested, but their parents have not been removed from them, and the father comes in, and I know that the father was the molester of this child, and that's why he's here. We don't have the right to tell the father to not come in. I wish we did. Sometimes we do. The court often will step in and say, yeah, no, he's not coming anywhere near. But until that happens, they still have their rights. I can't look at them in the face and smile and pretend that it's okay, because it's not okay. It is not okay to molest a child at all, period. So I have to remove myself from that situation, because I can't really talk to that parent, because I'm afraid I will say something that I'm going to regret later on. So I know that in myself. I've learned that over the years, that I'm not really that type of person. I don't think there's a lot of people out there that are, but some can cover it up better than others. I'm not one of those. I do have a poker face, and if I'm disgusted with a person, and that's pretty much the only thing that really disgusts me. Even after 35 years, and I've seen it all, that's the number one thing that I can't cover up my emotions on that one. So you're going to have to learn yourselves and what makes you uncomfortable, and if you're so uncomfortable that it actually shows on your face, that may be a time for you to say, can we switch patient? I am not good with this type of patient right now. Because they'll sense it, and they'll feel it, and you won't be able to get through. So as new nurses, everything's going to be frightening. Everything is new. You're always scared you're going to say the wrong thing or do the wrong thing, or you're going to make it worse. And triggers something else, or if you have a suicidal patient, well, I'm not going to ask them if they're still having suicidal thoughts. It's going to give them the idea. Well, no, guys, that's why they're admitted. They're admitted because they want us to help keep them safe. So by us asking them if they're still having suicidal ideations and encouraging them to talk about it, it gives them that avenue where they know they're not being judged and they feel that it's okay to talk about it. By trying to avoid the topic, they're no better off than they were at home when they didn't have anybody to talk to. So we are that avenue for them, and we need to make that message clear to the patients that whatever they say is always said in confidence. Everything, once you become a nurse, everything is confidential. You can speak to your coworkers if it's appropriate regarding the care of that patient, but that's as far as it's going to go. And you need to make sure that your patients are fully aware of that, so that when they do open up to you, they don't feel like you're going to run out and tell their mother what they just said, or their spouse, or that's where we come in, and that's how we can help them. If they think for a moment that you're going to disclose, particularly the adolescents, I find it takes them a while to warm up to. And they'll say, well, if I tell you something, are you going to tell my parents? No. If they tell you, I'm going to tell you something, but you can't tell anyone, that's a red flag. That means they're about to tell you something that you might have to tell someone. So you can open that up by saying, if it's something that is going to be considered a danger to you, and to keep you safe, I may need to tell your physician or your nurse. Then it gives them that opportunity to either shut up, not say anything, or to go ahead and tell you. One of the questions that's often come up is, what if they tell me that as soon as they're discharged, they're going to go kill their neighbor? Do we have the right to tell the neighbor? You do have the right to tell the police that they have this plan. But tell the patient that you're going to be doing it. I will have to pass this on to the police that you are still having these thoughts of killing your neighbor. But obviously, at that point, are they safe to be discharged? Probably not. So choose your words carefully when you speak with psych patients, but don't use too much silence. In other words, don't ignore them. Don't make them feel inferior to you. You're not there to, I'm a nurse and I know everything and I have all the answers, and no, we are their outlet, so use it wisely, and you're going to help a lot of people out there. I would like to think that I have in my career, and still plan to in the future, just as long as I don't wear green. But if someone tells you that the color you're wearing is making them uncomfortable, seriously, take it serious. Is there any questions out there that you guys might have about any type of psych emergencies, or things to expect, or what you should say or don't say? Any, yeah?
So, on the site unit, are there a lot of nursing staff there once a day, or are they doing it on time?
Are there a lot of patients that are on one-on-one?
Yeah, so do you have a lot of staff on that unit compared to the other units?
We could. It totally depends on the milieu of the unit. If we have even one patient that's a one-on-one, that's one staff just for that patient, period. And then you're going to have your core staff. We do probably staff it heavier than we do other units because of the safety issues. Obviously, you're not going to be admitted to a psych unit if you are fine. So some of them are just depressed and, well, just depressed. See, that's not cool. But some come in with major depression and it's very easily treated. Some come in, they're totally psychotic and will stir up the whole unit, where the whole unit becomes just one chaotic mess. So it totally depends on the milieu. Sometimes 2 staff is enough, 3, it will depend on a day-to-day basis. If it's a psych patient that is admitted to a medical floor for, say, an overdose or detox or overnight, they will automatically be put on a 1-to-1 basis. Because obviously on a medical floor, it's not a locked unit, higher risk of elopement, meaning that they can escape from the unit. Tons of wiring and tubings and telephone cords and call bells, and so we do have to watch them a lot closer when they are on the medical units. Any other questions? How many of you are interested in working psych or ER when you get out? Yeah? What's your preference?
I don't know. I'm not really sure exactly what you do anything really, but I like psych a lot.
Yeah. I find it's something, if you have it in you, it's great. Because it's a difficult unit to force yourself to like. Because if you're forcing yourself to like, you're probably scared of it. If you're scared, the patients won't know. If you automatically like psych, then you're probably already good at it and you know you're good at it. So, but you know what? No matter what unit you're going to work in a hospital, you're going to use your psych experience always. Whether it's a medical floor, surgical floor, OB. So it's never lost. Where would you like to work? Yeah. Is that where you guys are going to do your preceptors? Yeah. Do you know yet?
No, mine is good.
Med-surg? Oh, I can't go wrong there either.
One is overall.
You can't go wrong with med-surg. I'm a big fan of that because that's where you get your grounding. And you certainly use your sight there too.